Today we're going to be talking about oncologic emergencies and complications, and what are the most important things that you need to know in order to correctly identify and manage these patients. For neutropenic fever, you can refer back to my video on this subject, but briefly, you're going to be on the lookout for this when you see fever plus an ANC of less than 500, and the things that you're going to need to do is start them on broad spectrum antibiotics, definitely an anti-pseudomonal like cefepime, and then plus or minus vancomycin if there is suspicion for a central line infection, a port infection, or a skin and soft tissue infection. Also, we're going to typically get imaging. So in low risk patients, they do recommend a chest x-ray, but in higher risk patients, which is going to be a lot of these patients, you're going to be getting a CT chest. And also you want to get blood cultures, urine cultures, your typical infectious workup. And if they have abdominal pain, you also want to get a CT abdomen to look for typhlitis. 70% of these patients are never going to be found to have an infectious source. So once they are afebrile for 24 to 48 hours, their ANC is starting to get above 500, then you can stop the antibiotics and discharge these patients. If it's ongoing for greater than 4 days and you don't have a clear source, then you should start a fungal workup, including a CT sinus, and also start an empiric antifungal as well. Tumorlyis syndrome, typically we are going to be seeing this in patients with hematologic malignancies, and anything that has a very rapid turnover. So for example, small cell lung cancer is also high risk for tumorlyis syndrome. And they're especially at high risk right after you start the first cycle of chemotherapy because a lot of cells will be turning over and dying. And you just have to think about what is going to be released when these tumor cells die. So what is intracellular that's going to be released? It's a lot of electrolytes. So the things that you expect to see are going to be an increase in potassium levels, an increase in phosphorus levels, and an increase in uric acid, as well as an increase in LDH. The one thing that you will see that is low is going to be calcium, and that's because it's going to be binding to a lot of the phosphate that is kind of all over the place. Just because it's very common after the first cycle of chemo does not mean that you can't have spontaneous tumorlyis syndrome. You can definitely have just a lot of cell turnover in general, and so it does not have to be correlated with chemotherapy. Generally, what we do for management of this is we get Q8-hour tumorlyis syndrome labs, which is basically all of the above labs right here. And we also start them on fluids. It's typically normal saline, about 100 milliliters an hour, kind of depends on the chemo regimen that they're getting, as well as allopurinol for prophylaxis. Typically, the dose that I see is 300 milligrams BID. Now, what should you do if their uric acid level is becoming extremely elevated, and this puts you at very high risk for developing an AKI? Then a medication you can consider at that point is consider rasburicase if uric acid is greater than 8, or the uric acid level is greater than 25% from the previous lab check. How does rasburicase work? Well, it basically catalyzes the conversion of uric acid into allantoin, and basically that helps you to be able to safely get rid of the uric acid and excrete it. There is one specific patient demographic that is at risk if you give them rasburicase, and that is patients with G6PD deficiency. So ideally, you should have checked if they have a G6PD deficiency before you give them rasburicase, so you don't precipitate a flare of their G6PD deficiency, which may cause hemolytic anemia. For DIC, you guys all know that typically this is going to be when you're starting to see both clotting and bleeding simultaneously. In terms of lab markers, we look for a high D-dimer and a low fibrinogen. You may also see an elevated INR as well. The main treatment in this case is going to be treating the underlying cause. So in this case, these patients have malignancy. You're going to have to try and treat their malignancy to help get rid of their DIC. But one important thing is that if their fibrinogen goes below 100, usually we will treat this with cryoprecipitate. That's because cryoprecipitate contains fibrinogen, and that's going to help replace some of the clotting factors that you need there. And another useful test that we sometimes check in people who have really bad coagulopathies, just for your information, is called a TEG scan, which is called a thromboelastogram. And this basically can tell you which component of a patient's coagulation is causing their predominant symptoms. So for example, I always like to pull up this Rebel EM thromboelastogram graphic. You can just look for it on Google. But if you have a prolonged R time, then you treat with FFP. Prolonged K time and alpha angle, we treat with cryoprecipitate. An increased maximum amplitude is telling you that there's a platelet dysfunction. And then if the LY30 is high, then you're going to use tranexamic acid or aminocaproic acid. And this is not necessarily for DIC in general, but more so patients with coagulopathies in general when you're trying to find the specific part of their coagulation that is not working. Cord compression is going to present with lower extremity weakness, urinary retention, which can become urinary incontinence if you start to have overflow incontinence, as well as bowel incontinence. And you should be very suspicious for this if you ever see any of these symptoms in a patient with known malignancy. And of course, the thing that you're going to do here for treatment is going to be steroids plus a neurosurgery consult to assess for emergent surgical decompression. SVC syndrome is going to present with that facial swelling, as well as dyspnea is a very common symptom of SVC syndrome. And this is when you have mediastinal tumors, typically things like non-Hodgkin's lymphoma or lung cancers, even more particularly, that start to encroach on the SVC and block the venous outflow to the heart. And then so you get this backup of fluid, you get upper extremity swelling, facial swelling, all of these kinds of symptoms. And so if it is extremely symptomatic, basically what you're going to need to do is kind of do this multidisciplinary assessment with pulmonology, interventional radiology, and basically see if they need a stent placed in order to prevent those symptoms. Now, if they have a cancer that is very responsive to chemotherapy and it's expected that it's rapidly going to improve, sometimes you can get by without having a stent, but in many of these patients, you will need to have a stent. You also have to talk about anticoagulation because SVC syndrome, a lot of times when there's a mass there, you start to get a thrombus there as well. And you can kind of get this thrombus in mass situation going on. Now let's talk about leukostasis and hyperviscosity syndrome. Now these are both very, very similar, and the way they present is also very similar, but the etiologies are different. So leukostasis is going to be in your patients with leukemia, particularly in the myeloid leukemias, because the myeloid cells are thought to be big and sticky. In contrast, hyperviscosity syndrome is going to be seen in your patients with multiple myeloma or Waldenstrom's macroglobulinemia. It can actually be seen in up to 30% of patients with Waldenstrom's macroglobulinemia. And the etiology in this case is going to be from increased monoclonal proteins, whereas the leukostasis that we see is due to increased white blood cells. So what specific white blood cell count do you need before you get concerned for leukostasis? Typically, it's going to be greater than 100,000 is when you're going to have highest concern for leukostasis. Although you can have leukostasis at lower counts, especially in things like AML. Symptoms can be pretty similar, as I mentioned before, because both of them basically cause a clogging of blood vessels because of there's too many white blood cells or too many monoclonal proteins. And it includes things like neurologic, any assortment of CNS disturbances or abnormalities, headache, dizziness, shortness of breath. And so in leukostasis, if they are asymptomatic, you're going to treat the underlying malignancy, but you're also going to give hydroxyurea, which is a kind of cytoreductive therapy, and it kind of brings down all of your cell counts. If they are symptomatic, however, you are going to do hydroxyurea plus leukapheresis, which would entail them getting a central line placed in order to undergo that procedure. In the case of hyperviscosity syndrome, you're going to be giving plasmapheresis, which would get rid of those monoclonal proteins. Oh, and finally, what is it called when you have white blood cells above 100,000? That is also known as hyperleukocytosis. So just because you have hyperleukocytosis does not mean that you have leukostasis, but of course it's a risk when you have the white blood cells that high. I forgot to add one more oncologic emergency, and that is going to be hypercalcemia. And you can refer to my hypercalcemia video for some more information about this one. But in general, if it's calcium level greater than 14, then that is when we should treat. If it's greater than 12 plus symptoms, then you treat. And then greater than 10, typically we don't treat that. Our mainstays of treatment are going to be very aggressive fluids, like 200 to 300 cc's per hour. After that, you're going to give calcitonin if it's severe. And remember that this works very fast. It has a fast onset, but develops tachyphylaxis after 48 hours, which means it stops working after 48 hours, essentially. Then you've got your bisphosphonates, like zoledronic acid. And this one is takes about 48 hours to work, but then it lasts for like 3 to 4 weeks. And so that kind of gives you that perfect timing in between the calcitonin, dropping it acutely. And then as that's starting to wear off, that's when your bisphosphonates are starting to take over. Those are your 3 main treatments, but of course we have a whole variety of other ones. So diuretics, denosumab, if you have an AKI, denosumab can be used in renal insufficiency, whereas bisphosphonates can't. Also steroids if they have granulomatous disease that's causing this, as well as dialysis if it's super severe. All right, so cytokine release syndrome, ICANS, also known as immune cell-associated neurotoxicity syndrome, as well as differentiation syndrome. What are these? They're basically all kind of mediated by a similar mechanism, and that's going to be overactivation of your immune system and kind of this cytokine release, as it's in the name, cytokine release syndrome, that causes a variety of symptoms. And so cytokine release syndrome and ICANS, these are things that happen after people who have received CAR T cell therapy, if they've received a type of chemotherapy or immunotherapy that we use called a bispecific, or also if they've had a hematopoietic stem cell transplant. So what you'll see in cytokine release syndrome is things like fever, rash, hypoxia, and hypotension. And typically this happens pretty quickly after they receive the therapy, so hours to days after. Whereas ICANS is going to have more of those neurologic symptoms. So altered level of consciousness, seizures, speech changes. This one tends to happen 3 to 10 days after CAR T therapy, if that was the etiology, and also tends to happen after the cytokine release syndrome occurred. It's kind of a subset of cytokine release syndrome, a more severe subset. And the treatment is going to be steroids plus or minus tocilizumab. Also, you should basically just always call your oncologist as soon as any of these complications occurs. Differentiation syndrome is what we're going to see in patients with AML. So apparently this can happen in up to 1 out of every 5 patients in AML. And APML, which is a little bit more common, where we see it in up to a quarter of patients. Basically, as I mentioned before, you're again getting that increased cytokine expression because you are taking all of their immature cells, those myeloblasts, and causing them to differentiate into mature cells. And all of a sudden you have kind of this kind of immune reconstitution kind of picture where you're going to just get a lot of cytokine activation and cytokine release as this differentiation process occurs. So the symptoms are pretty similar to the above 2 conditions, but you get fever, weight gain, hypotension, you can get renal failure. You can tend to often get pulmonary opacities and kind of lung abnormalities, shortness of breath, and pleural effusions. These are all some of the symptoms that you may see. And in terms of the treatment, you want to actually continue therapy at addressing their underlying AML and APML. You give them steroids, and in general, just continue supportive care. All right, so this is my quick overview of all of the oncologic emergencies that you should be aware of. I also added in a couple extra details as I was going through this, but one of the treatments, if we have severely elevated FOS in tumor lysis syndrome, you should consider sevelamer. But I also wanted to discuss with you guys briefly about bone marrow transplants or hematopoietic stem cell transplants. So some of the things that we can see with this are engraftment syndrome, graft versus host disease, and something called sinusoidal obstruction syndrome. So what are the things that we kind of want to be on the lookout for in these scenarios? So engraftment syndrome is something that you typically see 9 to 16 days after bone marrow transplantation. And the reason it occurs is because you are now starting to create new white blood cells. And for some reason, this reconstitution of the white blood cells causes leaky capillaries, and you get increased capillary permeability. So the symptoms that you may see are going to be rash, hypoxemia, and just kind of diffuse pulmonary opacities is kind of the typical presentation of engraftment syndrome. In terms of the treatment, we really have to kind of rule out infection. And so sometimes empiric antibiotics will be given if there's any suspicion for infection. A lot of these patients are going to need a bronchoscopy with BAL in order to truly definitively rule out infection, just because these patients have no immune system. They're at very high risk for infection. Once infection has all been ruled out, sometimes steroids are going to be needed. And then if it's very severe, they may need to be intubated, but that is associated with a poor prognosis. Graft versus host disease is a pretty interesting one. And this is basically because you are implanting another person's immune system in, and you are developing white blood cells that are actually not your own body's white blood cells. It's actually the bone marrow transplant donors' blood cells that are starting to develop. And so what they can do is they can actually recognize your own body as foreign. So one thing to clarify really quickly is that you can have autologous stem cell transplant, or you can have allogeneic stem cell transplant. So autologous stem cell transplants is going to be using your own bone marrow to kind of transplant yourself. And basically this happens after somebody has a really bad malignancy and requires extremely intense chemotherapy that kind of wipes out their bone marrow. One of the things that they'll do beforehand is actually collect some of that stem cells that they have. And so after this intensive chemo regimen is done and their bone marrow is pretty much wiped out, they'll actually transplant themselves with their prior cells. And in that method, they can reconstitute their immune system. In contrast, allogeneic stem cell transplants are going to be from a donor that does not have your exact genetic material. And so this is from somebody else. And so in these cases, this is when you can get this risk for a graft versus host disease. There's also a type of transplant called a haploidentical transplant, which is kind of a subset of allogeneic stem cell transplant. So in most cases, they try to find a fully HLA matched donor for your stem cell transplant, but sometimes they aren't able to find that. So in order to get a transplant more quickly, they'll find a partial match, usually from a parent or a sibling, and this is called a haploidentical transplant. And so they are even less of a match than a typical transplant, and maybe that will even increase your risk of graft versus host disease even more. So getting back to graft versus host disease, this is typically in patients who have had an allogeneic stem cell transplant. So risk factors include HLA disparity, certain GVHD prophylaxis regimens, as well as a sex disparity between the donor and the recipient, as well as increased intensity of the conditioning regimen, which is basically the process of killing off all the bone marrow that is pre-existing in order to prepare the bone marrow to accept the new transplant. So GVHD really likes to attack the skin, liver, and the GI tract. And so one of the things you may see in graft versus host disease is you may see diffuse rash if it's involving the skin. Or liver, you may see hepatitis, elevated liver enzymes. In GI tract, nausea, vomiting, diarrhea, just abdominal pain, things like that. Again, steroids are sometimes used to kind of calm down this attack on your own body from these foreign white blood cells. But another thing to mention is that having a little bit of graft versus host disease is actually good. So a little bit of graft versus host disease is thought to have this anti-tumor effect, and it is particularly helpful in leukemias. So basically, because you have these foreign white blood cells going around and creating your new immune system, they actually are better at recognizing some of those cancer cells and just knocking out any residual cancer or disease that may be present. This last one here, sinusoidal obstruction syndrome, I just included because I had a patient that was one of my first patients in the ICU as an intern. And basically, it's if you see jaundice, ascites, and liver dysfunction after a bone marrow transplant complication, you can think about this condition called sinusoidal obstruction syndrome. Treatment is with ursodeoxycholic acid plus or minus antifibrotic agents like defibrotide. And finally, since I'm on the topic of BMT complications, I thought I'd just briefly go over some of the complications that you may see early and late. So of course, infection is a high risk, especially opportunistic infections, which typically in that first 6-month period is where you're going to see them the most. You may see liver damage, mucositis, cytopenias. You may see engraftment syndrome, acute graft versus host disease, diffuse alveolar hemorrhage, and pulmonary edema is a common complication. bronchiolitis obliterans, which is basically scarring of your lung tissue, and also AKI in up to 50% of patients. There's an increased risk if it's an allogeneic stem cell transplant. In terms of late complications, there are a ton of late-term complications. So again, you still have that liver damage risk. Of course, you still have an infection risk as well. Cardiovascular events are increased in these patients. ESRD, CKD, all very common. CKD, especially because you have calcineurin inhibitor toxicity. And you can also get this condition called transplant TMA, so thrombotic microangiopathies in the setting of a transplant. You can have chronic graft versus host disease, bronchiolitis obliterans, again, still going to be causing scarring down of that lung tissue. Pulmonary disease is also common, and you can get this thing called chronic lung allograft dysfunction. And finally, these patients are also at increased risk of developing diabetes, hypothyroidism, hypogonadism, all sorts of these other chronic diseases. All right, well, I hope that was a useful overview of oncologic emergencies and complications. Over here, we've got our typical oncologic emergencies and complications. Don't forget also that you have an increase in immunotherapy recently, which may be causing increased immune checkpoint inhibitor adverse events, which I have a whole video on as well. I'll link it at the end of this video as well. And then we've also got our bone marrow transplant complications over here. Mainly the ones to focus on are engraftment syndrome and GVHD, which are probably the most common ones that you're going to know about, but also knowing a very basic amount about the difference between autologous stem cell transplant and allogeneic stem cell transplant and how that affects your risk for GVHD. All right, I hope this video was helpful for you guys. Thanks again for watching, and I'll see you in the next one. Peace.